Thank you to all the Toronto team for inviting Adam and I here to join you. We're very honoured to be here and share our experience with you, and it's been a fantastic meeting for us so far. I should point out I'm from the other London, the original London. I know you have a London just down the road, but you can probably tell by my accent I'm from the other place. So I work about half my time actually in a paediatric hospital, and we take quite a lot of the paediatric work for the UK. We're a population of about 70 million people, so we're quite busy from that side, and we run the National Vein of Galen service between us. But I also have a reasonable adult practice as well. I have no conflicts of interest on this talk, but as Darren said earlier, all of the equipment that we use in children is used off license. So I'm going to talk to you about retinoblastoma treatment, and we have to talk more broadly about retinoblastoma treatment really to understand where selective chemotherapy might fit in. It's intellectually appealing to offer a selective treatment for any oncology. One can deliver maximum treatment to the abnormal cells whilst minimizing any toxicity to normal tissues. But we need to understand a bit about the natural history of the disease and look at the treatment strategies and rationales. Then we'll look at our local experience and compare that with what's published to look at efficacy and safety, and then a few comments about how we do it. So in terms of retinoblastoma, it's about 1 in 20,000 live births, which makes it about 3% of paediatric tumours. So in the UK, that makes about 40 new cases per year, and we manage that between 2 centres, although we're the only centre doing any significant volume of intra-arterial chemotherapy. So from the US, that equivalates to about 300 cases, and my estimate for Canada is about 20. I think your population's about half of ours. About a third of patients are familial genetic disorders, the RB1 gene on chromosome 13, and those tend to present earlier, partly because it's more aggressive disease and partly because we have screening processes for affected families, and that tends to be a bilateral disease. And the other 2/3 of patients tend to be sporadic germline, and those tend to be a unilateral disease, and they present later. It's actually the most treatable, most curable cancer in children, and in the developed world, about 95% of patients would expect to live beyond 5 years. However, that survival does drop to about 85% at 20 years, and that's mainly due to secondary tumours which occur in the familial subgroup. About 5% of patients present with less than 5% present with extraocular disease in the developed world. Things are completely flipped in the developing world. 20% of patients only about 20% of patients survive to 5 years, and about 90% are in places like Africa are presenting with extraocular disease, which obviously has a pretty poor prognosis. We all learn about the diagnosis at medical school, despite it being a rare condition, so the loss of red light reflex, strabismus. The diagnosis is fairly easily made on fundoscopic evaluation, and obviously there are some imaging requirements as well to stage the disease. Just focusing for a moment on the treatment strategy, with all oncology, the first treatment strategy is to preserve lives, but we are in an unusual situation in that we are usually preserving life. We have some very effective treatments already for this disease, particularly in the lower grade eyes. So increasingly, we're looking for a good cosmetic outcome, and we're looking to preserve vision in these children as well. And the third thing we're trying to do with our treatment to bear in mind is that we want to minimize late effects. As I said, these second tumors are a problem in the familial patients, and if we expose them to high doses of radiation, radiotherapy to the orbit and so on, we can theoretically increase those risks of second tumors. There are a series of staging classifications throughout the literature which have evolved over time, and they've really evolved with the treatment strategies. But in the developed world, we're going to be dealing with intraocular disease on the whole. And intraocular disease is graded from A to E. And just to simplify that for you, the A to B classification is really the low-grade eyes. These are small areas of tumour, limited to the retina. The A's are limited to non-eloquent areas of the retina, so don't interfere too much with vision. You move into the B grade if you have a larger tumour or if it's affecting the eloquent areas of the eye and affecting vision. The C and D eyes are the higher grade eyes, which are the ones which we have escaped from the retina. If we have local vitreous seeding, we call it a C eye, and if it extends further, more than 6 millimetres from the retina, it becomes a D eye. And those are the eyes, as we'll see, are the ones that have been primarily targeted in our service for this type of treatment. The EI the EI is what's considered to be the unsalvageable eye, the one which is heading towards a enucleation, although there is some progress on treating EIs with local therapies, and obviously the metastatic disease, which we rarely see. So there's a whole range of well-established local therapies, particularly pertinent to those low-grade eyes. Interestingly, retinoblastoma isn't curable by intravenous chemotherapy, but it can be curable when those treatments are associated with the local therapies. But in the good-grade eyes, many groups are treating that localized disease just with local therapies, and that seems to be satisfactory, although they clearly need surveillance. The higher-grade eyes are traditionally treated with intravenous chemotherapy. In the past, they have been effectively treated with external beam radiotherapy, but delivering those large doses of radiation to developing eyes and developing adjacent brain structures clearly has implications in second tumour formation, and we're moving away from that. And obviously the curative treatment for the higher grade is the enucleation. So why would we need this? We've already got very effective treatments for retinoblastoma. Well, as I've said at the start, it is appealing in a child to be able to offer a very therapeutic treatment with minimum toxic effect. They don't get the bone marrow suppression and the risks associated with that, and they are significant risks of secondary infections and so on. They don't need a central venous catheter indwelling, and you may well be able to salvage vision. Here we have a CI, top left, which has been successfully treated by intraarterial chemotherapy. At the bottom right, you can see the normal fundoscopic outcome. And obviously preserving eyes is very nice for cosmesis. And as I've said, it does. If we can avoid the very high radiation doses to the orbit with external beam radiotherapy, then we could predict that we would see fewer late effects. But of course, we're introducing a whole new series of risks here because we're putting something into the cerebral circulation, injecting something into the ophthalmic artery. The effects might be limited in vitreous disease. We're targeting obviously the retina and the choroid. And obviously, if you're considering this as your primary treatment and bypassing the IV chemotherapy, then there is a risk here that actually you've missed some seeds that are extraocular and you're offering no treatment for those. So you may be allowing some disease to escape. So those are the concerns. Nothing in interventional radiology is new, is it? This is a paper I found in 1955 when they were injecting into the internal carotid artery a chemical in association with radiotherapy in an attempt to treat retinoblastoma. But the more recent developments in the literature in the late 90s, the Japanese groups were beginning to use a targeted therapy. They were using a balloon catheter distal to the ophthalmic artery in the internal carotid artery to occlude flow, and then infusing chemotherapy through the more proximal lumen of this catheter, and reported some very good results, but this didn't really get global traction. The next time point really was Goban's group in New York, who published in 2008 their small series of super selective catheterizations, and that really reflects the developments in microcatheter technology, allowing us to actually selectively access the ostium of the ophthalmic artery, and that really has opened the doors for the rest of us. This is our local experience, and we started shortly after that publication with our chemotherapy treatments, and we were offering them specifically for the DIs and a few EIs, but only patients who'd been through the IV chemotherapy treatment already and had proved either refractory to that or had relapsed. And this was our protocol, which has remained fairly standard. For the first year or two, we were offering 2 cycles of treatment. We now offer 3 cycles every 4 weeks. We initially used melphalan alone. We now use melphalan and topotecan, which seems to be fairly standard. And we perform an examination between each treatment to assess whether the patient is stable or whether they're in remission or whether they're progressing. So this was around about the beginning of this year. We'd done 329 treatments in 102 eyes in 92 children. Several children were having more than 1 cycle. 10 children had bilateral eyes treated by this, and only 1 child where we were unable to treat due to anatomical considerations. They were approximately equal male and female, and approximately equal left and right. You can see that the mean age was 3.2 years, but we were doing children as young as 6 months. That was the familial cases, and the oldest child was 12.5 years, which is very late for retinoblastoma. And conversely, about 2/3 of our patients were the familial condition, as opposed to what we find in our incidence, which is about 1/3. So they're overrepresented in this group with more aggressive disease. Now, this is very preliminary data which I was able to access last week, and I wanted to put it in because it shows you roughly what you can expect. And I think in Toronto you're starting a similar kind of process to us, so I think it might be helpful to show you what we found. So of our 102 eyes, if you're looking at the first cycle of the first course of chemotherapy that you're offering, we're seeing that actually patients are progressing during that course. So we can see 8 are progressing after the first course, and 6 are progressing after the second, and 4 after the third. And then those patients who are either in complete or partial remission, or at least stable after that course, we then see 15 of those going on to relapse. So it's not a perfect treatment, but we're looking at what's a refractory group to the systemic chemotherapy. But we are getting about half of those patients who are stable. Of those patients who progress, they either have a further course of chemotherapy or they have adjunctive therapies, but most of them are heading towards enucleation at that point to preserve life. We wanted to take a view after our 90 or so patients to see really how we were doing against the rest of the literature. And again, like most pediatric literature, we have a large number of small volume series. I guess what I describe as the kind of me first papers, people publishing their first 10 or 15 results. Very, very disparate protocols, treatment protocols, very different outcome measures. But in 2016, there were these 2 attempted systematic reviews, which I think are quite useful. One, the first by an oncology group, and the second by Monica Pearl and a neuroradiology group. You can see that they've actually got relatively small numbers of patients and relatively small numbers of papers selected out of the many tens that are available. But it does allow us to get some kind of figures on what outcomes one might expect. So when we look at our globe salvage, we're actually salvaging about 60% of the globes that otherwise would have had a high chance to go on to enucleation. So we think that's reasonable. We'd like that number to be higher. But when we look at the literature, the first oncology paper, they're salvaging approximately 60% of the high-grade eyes, D to E. In the Monica Pearl patient, they don't really grade them according to the eye grading, but they do look at refractory disease. And they're actually getting, for refractory disease, they're getting higher globe salvage rates than we are achieving. But I think those are vaguely comparable. And certainly with this, we don't want more patients developing metastases because we've gone for a slightly more, we're not enucleating enough patients. And we were reassured to see that only 2% of patients in our group had metastatic disease. We had 1 patient who died from metastatic disease, other patients in remission. The things that are not measured and haven't been measured by us or any other group yet is what might be the most important to the patient, most of those patients, whether they actually have useful vision or not. And that's the whole point of what we're doing. So we're now looking more specifically about useful vision, and that's perhaps harder to measure than you might think, but it's certainly not really been measured significantly by other groups. And obviously we need the longer-term follow-up to look at second tumours. It is quite a morbid pathology, so the common things that we see are periorbital erythema and swelling, occasionally loss of eyelashes, some discomfort. We were reassured to see that our levels were perhaps a bit lower than those published. Of course, it depends how you're measuring these things. We are seeing ptosis, but that was a temporary finding, and it recovered in all of the patients, and we were seeing temporary dysmotility syndromes, 5% third nerve, 1% sixth nerve. Again, those recovered, and those again are comparable to what's been published. The more serious complications obviously are a concern. We are seeing vitreous hemorrhage in 6% of patients. Again, it's in the middle of the other groups. That is part of progressive disease, of course, but we felt that those were probably attributable to the treatment. Certainly choroidal and retinal ischemia is not part of the normal disease process, and we're seeing that in about 5% of patients. We saw just 1 patient with a permanent third nerve palsy and very low levels actually of neutropenia, which is very gratifying. The one thing we do see in our group, and we've published on, is this physiological reaction, a quite marked bronchospasm reaction, or as it's described. But this is a strange phenomenon. We'll talk a little bit about it towards the end of the talk. This is a summary of our talk. We use a 4 French system. We heparinize from puncture. We use a 4 French vertebral catheter, and then we use the Magic microcatheters almost exclusively from Bolt. We use either a 1.2, 1.5 or 1.8, and we occasionally use intraarterial glycerol tinitrate injections for spasm at the ostium. The things we're looking for, if you can see it on that bottom injection, is we'd like to see a choroidal blush, we like to see antegrade flow in the ophthalmic artery and very limited cerebral escape, and then the infusion takes place from the oncologist. What we found quite early on is that in a number of patients with more challenging anatomy, it's really quite difficult to lodge a catheter at the ostium. And we were increasingly using microcatheter and microwire techniques to actually catheterize more distally into the ophthalmic artery. This seems to be something that's quite unique to us. Not many other groups are doing this. But it does allow you in those difficult patients to get a nice stable position and to deliver directly into the ophthalmic artery. The other major anatomical anomaly that we need to be aware of is the accessory supply for middle meningeal. So this is a patient who you can see has got a very small ophthalmic artery, and our attempts to catheterize it have caused a bit of spasm. We haven't got very good antegrade flow. But when we inject the external carotid arteries, this is a lateral view, we can see the middle meningeal artery. We can see the middle meningeal artery here, and we can see an accessory supply to the ophthalmic artery, which is barely visible here, but as we go through the angiogram, you can see the ophthalmic artery filling back retrogradely to its ostium here, which you can see slightly stenotic at the origin of the carotid artery. So if we put a microcatheter all the way up to that position, we see beautiful filling of the ophthalmic artery here with a choroidal blush. This is a very acceptable place to deliver chemotherapy from. In terms of the physiological reaction, what's interesting about this is that not all groups describe this. But we published this in 2013 because we thought it was important, because we also heard that several other groups were seeing this and were actually stopping their treatments because it was causing anxiety. So we find this never in the first patient. I say never. In fact, I had a patient earlier this year who did have a mild reaction on their first treatment, but before that, never in the first treatment. Worst on the second treatment with subsequent improvement. And what we see initially is a 50%, more than 50% rise in the end tidal volume, which sounds like bronchospasm, feels like very stiff lungs. And then shortly after that, not invariably, but usually we see a 50% drop in the systolic blood pressure and a profound bradycardia. And this is what we published in our paper showing those physiological results. So here we start the treatment. Here you can see the blood pressure dropping from an initial normal level down to about 140. And responding with adrenaline, and you can see that's the heart rate, and this is the blood pressure over here, seeing these profound drops in blood pressure from a mean arterial blood pressure of 60, dropping down to about 20 here, and responding very rapidly to these small epinephrine boluses. It doesn't happen in all patients. We're seeing it in about 14% of all treatments, and about 30% of children on second treatments, more commonly in the smaller children. So far, we've not had a clinical reaction in response, a clinical complication in response to it, but there are concerns that this might be aggravating the retinal ischemia. So we've always been very aggressive in managing it with epinephrine to support the blood pressure. Just a final case, cautionary tale. So this is an 18-month-old girl who presented with familial retinoblastoma with intraocular disease. She'd been formally staged. It was stage D in the right eye, and it was refractory. So she was a good case for our protocol, but there's something on that angiogram. I don't know if anyone can see it. You see an area of calcification here, which we spotted during the procedure. And what hadn't been reported on the staging scan was that she actually had a lesion in the pineal region and had a pineal blastoma. So she actually had the trilateral retinoblastoma, which we see in 1% of familial cases. She had surgery for that. It was removed with a nice looking outcome, but sadly 8 months later, you can see that she's got this peel enhancing process that's really everywhere through the basal cisterns and down over the cervical cord. She went on to have radiotherapy of the lower cord, but you can see there's really extensive disease here, and she's the one patient who's died from that disease. So in summary, it's a very promising technique, but there is morbidity, and if you're going to start this, you're going to see some orbital complications. I think we need to decide where we put this in our algorithm. I think we've been very cautious sticking to those high-grade eyes. A lot of the literature does report responses in good grade eyes, and clearly you're going to get better outcomes in those. There may well be a place for concurrent vitreous treatments, particularly in the D and E eyes, and we're certainly looking at that. The physiological reaction, we believe, is real. We've looked at all the other possibilities, anaphylaxis, vagal conditions, but it doesn't seem to really match into those, and it does seem to get better with time. Obviously, a randomized controlled trial would be great here to look at intraarterial versus intravenous chemotherapy, but the numbers we've seen are very small, and it would need collaboration. This is clearly a team effort. These are the two people that really set this service up in 2008. Judith Kingston, who's an oncologist who very sadly died prematurely last year, and Stefan Brew, who some of you will know, very much alive, but working in Auckland now, and left us to Adam and I to run this service. Thank you very much for your attention.